Here's our highly structured, no-nonsense agenda to really hardwire this into your memory. We'll be hitting classification, management pathways, a key clinical pearl, classic exam traps, and then we'll finish up with a quick recall test. Okay, Section 1, Classification and MDF Basics. Now, before we can even think about treating a patient, we have to know exactly what we're dealing with, right? And more importantly, just how severe it is. That's exactly what the MDF is designed to do. So what actually is it? Well, Maddrey's discriminant function, or just the MDF, is fundamentally a prognostic classification and severity score. But here's the absolute critical part you've got to remember. It's used specifically in alcohol-associated hepatitis. This is not a general liver score for just any cause of cirrhosis or hepatitis. When you see a clinical vignette with a patient who has heavy alcohol use presenting with jaundice, fever, and tender hepatomegaly, this scoring system should instantly jump to the forefront of your mind. Let's break down the formula piece by piece. I know it might look like a bit of scary math at first, but it's actually really straightforward once you see the components. You start with a constant multiplier of 4.6. You multiply that by the prothrombin time difference, which, by the way, is simply the patient's PT minus the control PT. Then, you just take that resulting number and add the patient's total bilirubin in milligrams per deciliter. That's it, 4.6 times the PT difference plus the total bilirubin. Now take a look at this massive number right here, 32. I really want you to look at this number and just burn it into your retina. In the context of the MDF, 32 is the absolute critical threshold. It's the dividing line that dictates the entire trajectory of your patient's management. Every single medical student resident must know this number cold. Notice the stark contrast between our two clinical scenarios here. If you calculate the MDFI and it's strictly less than 32, well, you're dealing with less severe disease. However, if that score comes back at 32 or higher, your diagnosis automatically shifts to severe alcoholic hepatitis. Literally, the moment you cross that threshold, you're in a completely different clinical scenario with much, much higher stakes. All right, moving into Section 2, Management Pathways in Clinical Practice. We're transitioning rapidly from how we score the disease to how we actually manage it on the floor. First up, let's look at the management for an MDF of less than 32. Because this is less severe disease, our primary pathway is supportive care. The absolute cornerstone here is alcohol abstinence. Next is robust nutritional support, mostly because these patients are very often severely malnourished. Beyond that, you're focusing on managing any general complications and treating underlying infections or precipitating factors. Basically, it's a proactive, supportive approach to let the liver heal. But let's shift the tone for a second to reflect the gravity of the other side of that coin. An MDF of 32 or greater indicates severe alcoholic hepatitis. And the crucial point here is that this classification carries a significant short-term mortality risk. We are talking about a medical emergency that requires a much higher level of vigilance, aggressive monitoring, and a rapid escalation in our therapeutic approach. So how exactly do our management steps change for an MDF of 32 or higher? First off, these patients absolutely require hospital admission. Just like the less severe group, they need intensive nutritional support and strict, uncompromising alcohol abstinence. You also have to aggressively assess for concurrent infection and impending organ failure. But here's the major pivot. For patients with an MDF of 32 or greater, you absolutely must consider corticosteroid therapy, provided, of course, they're appropriate candidates and you've excluded major contraindications. Now, if you do decide to initiate corticosteroids, your job isn't done. You can't just write the order and walk away. Step 1 is initiating the steroids. Step 2 is assessing the treatment response after initiation, and we do this using another tool called the Lille score. If that Lille score indicates they are a poor responder to the steroids, we move to Step 3. You discontinue the steroids. At that point, you really need to consider specialist management, because continuing steroids in a non-responder just exposes them to dangerous immunosuppression without any therapeutic benefit. Moving right along to Section 3, Key Clinical Pearl, our highest yield takeaway. Let's distill all of this down into your rapid revision cheat sheet. Listen, if you remember absolutely nothing else from this explainer today, I want you to hammer home this one single rule. An MDS greater than or equal to 32 equals severe alcoholic hepatitis. That is the trigger for aggressive management and the consideration of steroids. Never, ever forget that severity threshold. And to help you calculate that on the fly, here is your rapid mental shortcut for the formula. 4.6 times a PT prolongation plus bilirubin. Remember, PT prolongation is just a faster way of saying the patient's PT minus the control PT. So 4.6 times PT prolongation plus bilirubin.
Keep that locked in your mind for rapid clinical recall on the wards or during your exams.
Section 4, classic exam traps. Don't be tricked. Listen up because we're entering dangerous territory now. These are the exact specific concepts that exam writers will use to trick you, and we're going to make sure you don't fall for them. Okay, the first trap is confusing your liver scoring systems. You must draw a sharp, authoritative distinction between the MDF and the MELD score. The Maddrey discriminant function is used exclusively to determine the severity of alcoholic hepatitis. The MELD score, on the other hand, is used for estimating prognosis and mortality risk in advanced liver disease of any cause, and it's the primary tool used for transplant prioritization. They measure different things for completely different purposes. Do not mix them up in a multiple choice question. Here is the second, and honestly, arguably more dangerous clinical trap. A high MDF, meaning a score of 32 or above, does not automatically mean you blindly prescribe steroids. Hitting that threshold is not a blind green light. It simply means steroids are indicated if and only if it's actually safe to give them. So take a look at this clinical checklist before you even think about writing that steroid order. You have got to assess for absolute contraindications. Does the patient have an active infection? If you give steroids, you're going to suppress their immune system and make it so much worse. Do they have ongoing gastrointestinal bleeding? What about severe renal dysfunction or other major complications? You have to aggressively rule out these contraindications first. Only when the coast is totally clear can you proceed with corticosteroid therapy for severe alcoholic hepatitis. Let's hit Section 5, quick recall. Test your knowledge. You've learned the classification, the management, and exactly how to avoid those traps. Let's put your newly structured knowledge to the test right now. Here's your clinical scenario. You're evaluating a patient with suspected alcoholic hepatitis. You pull their labs. The patient's PT is 30 seconds. The control PT is 12 seconds. Their total bilirubin is 10 milligrams per deciliter. I want you to calculate the MDF and give me the clinical interpretation. I'll give you a couple of seconds to just do the mental math. Okay, let's break down the math step by step to see exactly how we derive the answer. Step 1, we set up the formula. 4.6 times the PT difference, which is 30 minus 12, plus the bilirubin of 10. Step 2, we calculate that PT difference. 30 minus 12 is 18, so it's 4.6 times 18 plus 10. Step 3, 4.6 times 18 is 82.8. We add the 10 for bilirubin, and we arrive at our final MDF score of 92.8. And finally, our interpretation. Because 92.8 is way above our critical threshold of 32, this patient definitively has severe alcoholic hepatitis. They require admission, strict supportive care, and an immediate evaluation for corticosteroid therapy. But before we wrap up, I want to leave you with one final provocative question. What happens if your patient hits an MDF of 92, but they have a massive GI bleed making steroids impossible? How do you save the liver when your primary weapon is strictly contraindicated? Well, that's where you'll need to explore advanced rescue therapies and that little score we talked about next. Thanks so much for joining me on this explainer. Study hard, and I'll see you next time.